Alice, you have one RT in your ICU that is amazing. I love her to death.
Nikan?
Yes, 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 yes.
Welcome back to PeteScript. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow in Washington, D.C.
So Alice, what do we have today?
Today, we are talking about how to get your patients with a new tracheostomy home and how to really set expectations with the family. So we've got Dr. Parisa Kaviany, a pulmonology attending at Children's National in D.C., and Dr. Maria Arroyo, a pulmonology attending also at Children's, who really focuses on that chronic lung disease population.
So a great practical conversation to help walk a family through what to expect after they leave the ICU. Let's get right to the content. I think it might be helpful for us as ICU learners to understand how you think about choosing a goal vent setting for a patient, and that being the last step perhaps, or one of the last steps for being able to leave the medical system and get back home.
Baseline settings will be the settings that will give the patient the freedom to tolerate physical therapy without any events, to tolerate regular cares by the nursing or the caregiver without any major events. And then on top of that, the settings that will give the patient what they need is that great ventilation, very little oxygen, and then also give them that respiratory stability. And that's what I meant with respiratory stability, that they are able to tolerate. That's the first thing I asked the bedside nurse. Is like, is this patient getting physical therapy? How is he doing when he sit up? Does he desat or not? Can he tolerate physical therapy for 20 minutes that they are working with him? How many times do they come and see him? So those are the things that tell me, I think he's ready. And then, of course, and I think from the ICU point of view, you want the patient to do as much effort as they can. If the patient don't have any other reasons to keep a rate that is enough for age, but maybe an optimal one to help him ease and recover from the acute illness that they have, and let them do as much effort as they can do, I think those are the best settings for them to recover over time.
I think it's helpful.
Yeah, especially the activity. Honestly, haven't been thinking about that.
I always think oxygen's a good place to start too, because when you think about the equipment that a kid is going home with, like, yes, if they're on a ventilator, they will have oxygen in the house, but it makes a big difference whether they need portable oxygen or not. So, when you're weaning the FiO2, if that means you go up a little bit on the pressure, but you get the kid on room air, that could be a big quality of life difference for the family when they're trying to transport. So that's something that I think about often, especially when like our oxygen requirement, gets in like the range of the 20s, is like, is it necessary or can we overcome this?
That's great.
By adjusting some other metrics.
That's also very tangible. When we do finally get these kids home after subacute, what does pulmonology follow-up look like? I know that you guys are the number that the parents would call if they were, besides 911, if they were having a problem in the middle of the night. But how do you establish a good follow-up, catch them after they leave?
Our practice in pulmonary is to follow up in 4 to 6 weeks after discharge. Sometimes that might not be a possibility, so it can go even to 8 weeks, so 2 months. That's why we want to obtain that respiratory stability to be able to go on for longer. But of course, the patient needs a follow-up with, I would highly recommend to send the patients or connect them with a complex care pediatrician that they are very much aware of troubleshooting. Even with, I have some of our amazing complex care pediatricians here at Children's National, they email me and like, this alarm is going on. I know we need to change this. I'm going to send the order. And I'm like, this is great. Yes, they have the capacity of doing that. And then the other thing is that once you have a very educated parent, they are able to troubleshoot anything. I have a father that is not needed for every single patient, but he learned the guide. And so there is, for example, the Astral vent, the Astral 150. There is, how do you say the book that where you learn
he
how
read
to
the
use
manual?
Manual.
Wow.
The manual in the internet in a PDF, and the father learned every single thing, every single alarm, how to troubleshoot everything. So I learned a lot from him, by the way. So that's kind of like the overachiever parent, and I applaud him for that. And it was great because during the pandemic, Especially, I want to touch base about the follow-up because some people think that because they are on a ventilator and a tracheostomy, they need to be seen in person. And I think once you have as a pulmonologist, once you have a good grasp of the patient, you say, next time let's see each other via telemedicine. I think telemedicine is here to stay. It's not going to go away. And actually, we had hard times during the pandemic because I follow babies with severe BPD who are tracheostomy and ventilators. And these babies went home at that time. So we did a lot of telemedicine, and these parents, I have to go through the video and say, change the beep from 8 to 7, click here, click that. So the parents learn a lot. But we were able to I win 2 babies off the ventilator during the pandemic via telemedicine. It's not the best way. I think, extreme cases and circumstances, make you do amazing things. But I think telemedicine is here to stay, as I said, and I think you can have a combination of both. Especially, for example, if a patient is pretty stable, you don't need to measure O2 or CO2 monitoring in the office, then you will be able to do those visits. It's like any alarms, any event, any accidental decannulation, any need of bagging or giving extra oxygen, how are secretions, things like that. That is a conversation that could happen over the phone. You can have a video chat and take a look at the patient and see the stamina, the face, how the work of breathing is, the ventilator settings that tells you a lot of things. And actually, I've been seeing the benefits of doing telemedicine because I can check exactly what equipment the patient have at home. And you cannot imagine how many things I'm like, that shouldn't be like that. You have to change that. I need to call your company because this shouldn't be like this. So it's actually pretty good because I'm like, Mom, show me how the ventilator looks. Let me see your setup. Let me see how you give oxygen. Let me see how you blend it to the BiPAP. The bypass machine, the mask, how they put it on, things like that. So I think it's pretty beneficial, and it can be a combination of both, of in-person and telemedicine.
Nice.
I think that's really neat. You think about how difficult and labor-intensive it is to get that patient to come to your office. And if you can safely do much of that over the phone, I think that's a great benefit for our families.
Yeah. Some families don't have a car, so their only ride is an ambulance that they have to wait for them to arrive. And it's scheduled. And if the ambulance is busy and they cannot pick them up, they're not going to be on time. So that's why my patients in the clinic, sometimes they're late, but what can we do? We have to see them because it's very difficult for them to move them, especially because of the amount of equipment that they have.
Oh, yeah. Are there other common post-discharge pitfalls that we should be aware of that you guys can think of? I'm sure there are so many things that I haven't even scratched the surface of.
One thing that is very important, and I see this all the time, even in the hospital or at home or in the office. The tracheostomy and the tubing that goes to the ventilator, there is always humidification, especially when the patient is in the ICU or at home. There is water vapor that goes through the vent and goes to the airway. If the patient is in the clinic, they can use an HME, that is a filter that brings moisture from the air and keeps the airway moisture for the ride. Sometimes when you have the tubing, so for example, imagine if the patient is laying down, if the tubing of the ventilator is above the head, he's going to get all the rain down. So one practice I always tell the parents is that the tubing should be below the head of the patient going down so it can rain down. I've been consulted for patients that get desaturations intermittently throughout the day and night, and we don't know why. And then we realized that the tubing was hanging from up top. So we're like, just put it down, and then everything resolved. That's one thing that I see a lot. And then the other thing that I think is really important is to point out to the families that you guys know the emergency kit that they have, a small size trach, suction catheters, ambu bag, and everything. That bag should always be next to the patient, not in the car, always with the patient. Even if the patient is in the clinic, they cannot leave it in the car. Always in the ICU is always next to them hanging. So that part of the emergency kit should always be with my child next to him, is part of him. I think it's very important because some parents say, oh, that's the emergency kit. I don't need it all the time, you know? is very important. So for example, if we see a patient here in the clinic that doesn't have the emergency kit next to them and they are in the car, I have to run to the ICU, or maybe I have some ambu bags here. Parisa can tell all the ambu bags hanging because we share offices, because we have to give them an ambu bag in case of something happen in the clinic, because things can happen at any time.
And I think one thing that we haven't talked about enough today is the role of the respiratory therapist. And so while as pulmonologists, we're super involved in the care of these patients at home, every home care company has respiratory therapists that work with them, and they do home visits. So a big part of discharge for me when I'm thinking about a patient going home is, has the parent been trained on how to use the ventilator by the home care company? And then has an RT home visit been set up? And I typically like for them to get another one the following week or in the following 2 weeks to make sure that everything is going okay. It allows for a clinician to be able to check in on the home environment and make sure that things are set up as they're supposed to be. And it helps a little bit more with the technical troubleshooting of the equipment.
Now that Parisa touched base on that, just want to give you a trick for both of you. In the ICU, when you get a patient admitted that is trach and vent and you have no clue what are the baseline settings or anything, you can get everything online if the patient has the access to it at home. So they should have something at home that is a Wi-Fi antenna or something that we can see live how the patient is breathing. So some patients pay for it. That's a separate service that they need to pay. Some insurance don't cover, so some patients don't have it, but you can always contact the DME company that is the sticker attached to the ventilator. Call that number and say, fax me right now the data from the ventilator, and you get all the information and your life will be so easy.
Oh my gosh. Wait, so it's...
Wow.
It gets uploaded the way that...
There is a website, and then you can get access as a caregiver, especially in the ICU. And then the company who provides the Astral ventilators, ResMed, is called AirView. And then you have a login, you go in, you search your patient, all the patients are there, and then you search your patient and see the data from the ventilator.
Wow.
It's how we get like compliance data too for CPAP or BiPAP use at home.
Oh my gosh. This is...
Yeah,
Life
that's great.
is good.
Oh.
We'll have to share that. Since you're dropping pearls, anything else that you want us to know in the PICU next time we admit one of our chronic vented patients?
I think that's the main thing. You guys always call us for what are the settings for this patient? We're like, oh, let's figure this out.
The home, it's never, we
That's
never
right.
have the right home settings. It literally doesn't matter. I can't believe that there's a live
That's right.
feed. This is crazy.
But I think that's okay, because at the end the patient is coming for that acute illness, so you guys do whatever you need to do.
We're not putting them on there, but
That's right. Bring in the servo. It's like, I'm not sure about that other vent.
Bring the servo. And I think the other thing that I have learned, when I was training as a pulmonologist and now, is that your best friend should be the bedside RT. They have so much knowledge to give you. They know pulmonary physiology. Alice, you have one RT in your ICU that is amazing. I love her to death.
Nikan?
Yes. But there are many, right? That's one, but there are two more that I remember. They're so good. And they tell you so much information that you're like, I got it. I know what to do. I know exactly. They can tell you long compliance. His compliance is getting worse compared to yesterday, especially if they have been there for many days. They know the patient from top to bottom, so they can tell you the alarms, the peak pressures, what you should do about that, or what they will, not what you should do, but what would they recommend to do. Ask them. Get them involved. It's like, what would you do? Why not? Ask them about the equipment. Why are you using that tubing? Why are we not using this one? Can we get a smaller one? Is it too heavy on the patient neck? Things like that, they're so helpful. And of course, your nurses at bedside, they're like 24/7 there. So definitely they know a lot. But the RTs for that part of the ventilator, secretion management, airway clearance, pulmonary toilet, that should be your right hand. And I tell that to our pulmonary fellows. The RTs at bedside, if they're not at bedside, call them, because they know a lot. The thing is that they are not there all the time, and there is a shortage of RTs also everywhere in the country.
Sure.
So you have to call them because they are pretty busy, but they are very useful.
Absolutely. All right. Well, thank you both so much for talking with us today. We learned probably a little bit too much about
Experts.
So,
Yeah.
Oh, it's perfect. Oh, it's perfect. I just can't wait to live stream my patients.
Yeah. Thanks, guys, for this opportunity. It was really nice to be able to talk about this. I had mentioned a resource that would be helpful for patients and families who are trying to learn more about life with a tracheostomy. And the website for that is Family Reflections. And it just talks about different scenarios about whether home ventilation is how to make the decision, basically, for the families, a decision guide. Great. And then I also wanted to make a plug for the American Thoracic Society Pediatric Tracheostomy resources. They have like a patient handout about pediatric tracheostomy, sort of what it is and how it works and what it might mean for your child. And they're available for free online. So if you mention that word for the first time and there's no pulmonologist around for some reason, and you just need a quick resource to be able to provide families with, they have them in English and in Spanish.
Oh, that sounds perfect. Thank you.
Those resources are amazing. I think it's something that we can give to the parents. I remember a mother found this Instagram account. It's called Lily's Little Lungs. It's a mother's perspective of a kid with a tracheostomy and ventilator at home. And she gives these tricks and things that the parents can do at home that are really nice for quality of life. I highly recommend that. I have check it out. But just an example, a mother told me that from that account, or from a mother's perspective, his child was a severe BPD baby, 9-month-old, starting to crawl with a ventilator attached to his neck. So how can he do that? Well, in Amazon, you can find a thing that has wheels, and you can put the vent on it, strap it there, and then has a kind of like a strap that goes and wrap on the chest of the patient. And then the kid was like crawling, and then the vent was behind him.
That is
so
cute.
You're promoting growth. It's not amazing? And it was like $20 to buy on Amazon. So those things are the things that may change their life and improve them at some point that we don't know. We have no clue what it is to take care of a patient at home like this. So I love those accounts because it really helps. Of course, there are accounts there is a lot of people in it. So I usually tell the parents to take this with a grain of salt. The first thing that the parents do is like, I'm part of a Facebook group that has, I don't know, millions of people there. Of course, there are many cases, many things, and, every story is different. And I think we should individualize everyone's care. And one kid cannot be, and I think that makes the parents very uncomfortable when you say, I have a kid like him before, and I think we should do it. No, my kid is special. Mm-hmm. So I think we should take that into consideration.
I think this is fantastic. We'll be sure to share all the resources that you left with us today. And I really hope, one of the goals of this episode is to improve communication between intensivists and pulmonologists. And I think as our patients get more and more complex, we're going to have to go out of our way, have really effective communication that's ongoing to benefit the child.
Absolutely. That's the reason why we're all here, right? We want to make sure that our patients are safe, they're well cared for, and they're growing well.
And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Peds Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Peds Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.